Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, students. Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. My name is Crisel Merducanes, nurse educator, teaching medical and surgical nursing. As continuation on our topics on management of patients with chest and lower respiratory tract disorders, we have pulmonary heart disease or the cor pulmonale. It is a condition that results from pulmonary hypertension, which causes the right side of the heart to enlarge because of the increased work required to pump blood against high resistance through the pulmonary vascular system. And this causes right-sided heart failure. Now let's have the pulmonary embolism. It refers to the obstruction of the pulmonary artery or one of its branches by a thrombus or thrombi that originates somewhere in the venous system or in the right side of the heart. We also have a related condition known as the deep vein thrombosis or the DVT. It refers to the thrombus formation in the deep veins, usually in the calf or thigh, but sometimes in the arm, especially in patients with peripherally inserted central catheters. Venous thromboembolism. This is a term that includes both deep vein thrombosis and pulmonary embolism. For the clinical manifestations, we have dyspnea as the most frequent symptom. Then we have tachypnea, which is the most frequent sign. Patient might also experience chest pain, anxiety, fever, tachycardia, apprehension, cough, diaphoresis, hemoptysis, and syncope. Now let's have the assessment and diagnostic findings. First, we need to obtain a complete clinical history and assessment. We also perform chest X-ray and ECG. Pulse oximetry to monitor the oxygenation status of our patient. We also have ABG analysis, ventilation, and perfusion scan. Ventilation and perfusion scan continues to be used to diagnose pulmonary embolism, especially in facilities that do not use pulmonary angiography or do not have access to a spiral CT scanner. The ventilation and perfusion scan is minimally invasive, involving the IV administration of a contrast agent. This scan evaluates different regions of the lungs, the upper, middle, and lower, and allows comparisons of the percentage of ventilation and perfusion in each area. This test has a high sensitivity but can be more cumbersome than a CT scan and is not as accurate as pulmonary angiogram. For the prevention of your pulmonary embolism, we have to prevent the deep vein thrombosis as an effective approach by way of active leg exercises, early ambulation, use of anti-embolism stockings. For the medical management, we have here emergency management. The main goal of this emergency management is to stabilize the cardiopulmonary system. Also, we have the general management. It aims to improve respiratory and vascular status. Next, we have your pharmacologic therapy. It is to dissolve or lyse the existing thrombi and prevent new ones from forming. And we also have your surgical management. For your pharmacologic therapy, we use the anticoagulant agents or therapy. Then we have your thrombolytic, fibrinolytic therapy. For the surgical management, we have your surgical embolectomy. It is rarely performed but may be indicated if the patient has a massive pulmonary embolism or hemodynamic instability, or if there are contraindications to thrombolytic therapy. Embolectomy can be performed using catheters or surgically. Surgical removal must be performed by a cardiovascular surgical team with the patient on cardiopulmonary bypass. Although surgical embolectomy ensures removal of the clot, it is not without risk. We also have another surgical management which is called your transvenous catheter embolectomy. This procedure has a variety of techniques. We have your suction embolectomy, wherein there is a large lumen catheter inserted and the thrombus is suctioned by manually applying negative pressure with an aspiration syringe. We also have your rheolytic embolectomy. This is accomplished by injecting pressured saline through the catheter's distal tip that macerates the emboli. The saline and clots are then sucked back into the exhaust lumen for disposal. We also have rotational embolectomy, which involves a rotating device within the catheter to fragment the thrombus. The fragments are continuously aspirated. In addition, catheter-directed ultrasound combined with low-dose thrombolytic therapy has been studied and may offer benefit. We also have your inferior vena cava filter. It may be inserted at the time of surgery to protect against a recurrence. IVC or your inferior vena cava filters are not recommended for the initial treatment of patients with pulmonary embolism. The IVC filter provides a screen in the inferior vena cava, allowing blood to pass through, while large emboli from the pelvis or lower extremities are blocked or fragmented before reaching the lungs. Numerous catheters have been developed since the introduction of the original Greenfield filter. The choice of filter depends on the diameter of the inferior vena cava as well as the planned duration of placement of the filter. Some filters are retrievable and some are non-retrievable. It is recommended that anticoagulation be continued in patients with an IVC filter if there are no contraindications to its use. Now let's have the nursing management of your pulmonary embolism. It is focused on minimizing the risk of pulmonary embolism. The key role of the nurse is to identify the patient at high risk for pulmonary embolism and to minimize the risk of pulmonary embolism in all patients. The nurse must have a high degree of suspicion for pulmonary embolism in all patients, but particularly in those with conditions predisposing to a slowing of venous return. Next is preventing thrombus formation. Preventing thrombus formation is a major nursing responsibility. The nurse encourages ambulation and active and passive leg exercises to prevent venous stasis in patients' prescribed bed rest. The nurse instructs the patient to move the legs in a pumping exercise so that the leg muscles can help increase venous flow. The nurse also advises the patient not to sit or lie in bed for prolonged periods, not to cross the legs, and not to wear constrictive clothing. Legs should not be dangled or feet placed in a dependent position while the patient sits on the edge of the bed. Instead, feet should rest on the floor or on a chair. In addition, IV catheter for parenteral therapy or measurement of central venous pressure should not be left in place for prolonged periods. Next, we have your assessing potential for pulmonary embolism. All patients are evaluated for risk factors for thrombus formation and pulmonary embolism. The nurse conducts a careful assessment of the patient's health history, family history, and medication record. On a daily basis, the patient is asked about pain or discomfort in the extremities. In addition, the extremities are evaluated for warmth, redness, and inflammation. Next is the monitoring thrombolytic or fibrinolytic agent or therapy. The nurse is responsible for monitoring thrombolytic and anticoagulant therapy. Thrombolytic therapy, such as the use of agents streptokinase, urokinase, tissue plasminogen activator, causes lysis of deep vein thrombi and pulmonary embolism, which helps dissolve the clots. During thrombolytic infusion, while the patient remains on bed rest, vital signs are assessed every 2 hours and invasive procedures are avoided. Next is managing pain. Chest pain, if present, is usually pleuritic rather than cardiac in origin. A semi-Fowler's position provides a more comfortable position for breathing. However, the nurse must continue to turn patient frequently and reposition them to improve the ventilation-perfusion ratio in the lung. The nurse administers opioid analgesic agents as prescribed for severe pain. Next is managing oxygen therapy. Careful attention is given to the proper use of oxygen. The patient must understand the need for continuous oxygen therapy. The nurse assesses the patient frequently for signs of hypoxemia and monitors the pulse oximetry values to evaluate the effectiveness of the oxygen therapy. Deep breathing and incentive spirometry are indicated for all patients to minimize or prevent atelectasis and improve ventilation. Nebulizer therapy or percussion and postural drainage must be used for management of secretions. Relieving anxiety. The nurse encourages the stabilized patient to talk about any fears or concerns related to this frightening episode, answers the patient's and family's questions concisely and accurately, explains the therapy, and describes how to recognize untoward effects early. Next, we have the monitoring for complications. When caring for a patient who has had pulmonary embolism, the nurse must be alert for the potential complication of cardiogenic shock or right ventricular failure subsequent to the effect of pulmonary embolism on the cardiovascular system. We also have providing post-operative nursing care. If the patient has undergone surgical embolectomy, the nurse measures the patient's pulmonary arterial pressure and urinary output. The nurse also assesses the insertion site of the arterial catheter for hematoma formation and infection. Maintaining the blood pressure at a level that supports perfusion of vital organ is very crucial. To prevent peripheral venous stasis and edema of the lower extremities, the nurse elevates the foot of the bed and encourages isometric exercises, the use of anti-embolism stockings, and walking when the patient is permitted out of bed. Sitting is discouraged because hip flexion compresses the large veins in the legs. And lastly, promoting home and community-based care by way of educating the patient about self-care and continuing care. Now let's proceed to sarcoidosis. It is a type of interstitial lung disease. It is a multi-system granulomatous disease of unknown etiology. Sarcoidosis is thought to be a hypersensitivity response to one or more exogenous agents such as bacteria, fungi, virus, chemicals, in people with an inherited or acquired predisposition to the disorder. The hypersensitivity response and inflammation results in the formation of non-cassating granulomatose, which is non-infectious organized collection of macrophages that appear as a nodule. So for the clinical manifestation, so the signs and symptoms are insidious and they lack prominent clinical features. So patient might experience dyspnea, cough, hemoptysis, congestion. For the assessment and diagnostic findings, we perform chest X-ray and CT scans. These are used to assess pulmonary adenopathy. This may show hilar adenopathy and disseminated miliary and nodular lesions in the lungs. A mediastinoscopy or transbronchial biopsy, in which a tissue specimen is obtained through the bronchial wall, may be used to confirm the diagnosis. In rare cases, an open lung biopsy is performed. Diagnosis is confirmed by a biopsy that shows non-casating granulomas. Pulmonary function test results are abnormal if there is restriction of lung function, reduction in total lung capacity. Now let's have your medical management. So we administer corticosteroids. This is beneficial because of their anti-inflammatory effects. We also administer immune modulators. When there is inadequate response to prednisones or the dose cannot be decreased. Now let's proceed to occupational lung diseases or your pneumoconioses. It refers to a non-neoplastic alteration of the lung resulting from inhalation of mineral or inorganic dust. It is caused by inhalation and deposition of mineral dust in the lungs, resulting in pulmonary fibrosis and parenchyma changes. We have here common pneumoconiosis. First, we have your silicosis. It is acquired from glass manufacturing, foundry work, stone cutting. We also have your asbestos, acquired from shipbuilding and building demolition. We also have your coal workers' pneumoconiosis. It is also known as your black lung disease. It can be acquired from mixtures of coal, kaolin, mica, and silica. Now let's proceed to chest tumors. Tumors of the lung may be benign or malignant. A malignant chest tumor can be primary, arising within the lung, chest wall, or mediastinum, or it can be a metastasis from a primary tumor site elsewhere in the body. So we have two types of your chest tumors. We have your lung cancer, the bronchogenic cancer, and your tumors of the mediastinum. Lung cancer. The most common cause of lung cancer is inhaled carcinogens, most often cigarette smoking, which accounts 90%. Other carcinogens include radon gas and occupational and environmental agents. Arise from a single transformed epithelial cell in the tracheobronchial airways, in which the carcinogen binds to and damages the cell's DNA. Now let's discuss the classification and staging. Your lung cancer is classified into major categories. First, we have your small cell lung cancer. It accounts for 10 to 15% of the tumors. We also have the non-small cell lung cancer, and it accounts approximately 85 to 90% of tumors. And it is further classified as 2 their cell type. So we have your squamous cell carcinoma, large cell carcinoma, and adenocarcinoma. Now let's discuss the stage of tumor. It refers to the size of the tumor, its location, whether lymph nodes are involved, and whether the cancer has spread. So we have 4 stages. For stage 1, there is a high rate of cure. For stage 4, it designates metastatic spread. Now let's have the risk factors. So first we have your tobacco smoking, secondhand smoke, and environmental and occupational exposure. For the clinical manifestations, it depends on the location and size of the tumor, the degree of obstruction, and the existence of metastases to regional or distant sites. Cough or change in chronic cough, which is the most frequent symptoms. Also dyspnea as the early stage. Hemoptysis. Patient might experience chest or shoulder pain. Recurring fever. For the assessment and diagnostic findings, we have to perform chest X-ray and CT scans. Also, we have here your fiber optic bronchoscopy, which is commonly used. It provides a detailed study of the tracheobronchial tree and allows for brushings, washings, and biopsies of suspicious areas. For peripheral lesions not amenable to bronchoscopic biopsy, a transthoracic fine needle aspiration may be performed under CT guidance to aspirate cells from a suspicious area. And a variety of scans may be used to assess for metastasis of the cancer. For the medical management, the goal here is to provide a cure if possible. So we have surgical management, radiation therapy, chemotherapy, palliative therapy. For the surgical management, we perform surgical resection. It is the most preferred method of treating patients with localized non-small cell tumors, no evidence of metastatic spread, and adequate cardiopulmonary functions. So these are the criteria wherein we can perform surgical resection. So we have types of surgical resection. First, lobectomy. It is a single lobe of the lung is removed. We also have your bilobectomy. 2 lobes of the lungs are removed. We also have the sleeve resection. Cancerous lobes is removed and a segment of the main bronchus is resected. We also have pneumonectomy, the removal of the entire lung. We also have the segmentectomy. A segment of the lung is removed. Also, wedge resection, removal of a small pie-shaped area of the segment. Lastly, we have the chest wall resection with removal of cancerous lung tissue. This is indicated for cancers that have invaded the chest wall. Now let's proceed to the nursing management. First is to manage the symptoms. The nurse educates the patient and family about the potential side effects of the specific treatment and strategies to manage them. Strategies for managing such symptoms as dyspnea, fatigue, nausea and vomiting, and anorexia help the patient and family cope with the therapeutic measures. We also have relieving breathing problems. Airway clearance techniques are key to maintaining airway patency through the removal of excess secretions. This may be accomplished through deep breathing exercises, chest physiotherapy, directed cough, suctioning, and in some instances, bronchoscopy. We also have here reducing fatigue. Fatigue is a devastating symptom that affects the quality of life in patients with cancer. It is commonly experienced by patients with lung cancer and may be related to the disease itself. The cancer treatment and complications, sleep disturbances, pain and discomfort, hypoxemia, poor nutrition, or the psychological ramifications of the disease. Next, we have to provide psychological support to our patient. Another important part of the nursing care of patients with lung cancer is provision of psychological support and identification of potential resources for the patient and family. Now let's proceed to tumors of the mediastinum. It includes neurogenic tumors, tumors of the thymus, lymphomas, germ cell tumors, cysts, and mesenchymal tumors. It may be malignant or benign, and it usually described in relation to location, anterior, middle, or posterior masses or tumors. Now let's proceed to chest trauma. It may occur alone or in combination with multiple other injuries, and it is classified as blunt trauma and penetrating trauma. For blunt trauma, results from sudden compression or positive pressure inflicted to the chest wall. For the medical management, the goal here is to evaluate the patient's condition and to initiate aggressive resuscitation. So we also have complications of blunt chest trauma. First, we have your sternal and rib fractures. It is the most common in motor vehicle crashes with a direct blow to the sternum via a steering wheel. We also have the frail chest. Occurs when 3 or more adjacent ribs, multiple contiguous ribs, are fractured at 2 or more sites, resulting in free-floating rib segments. Lastly, we have your pulmonary contusion. It is defined as damage to the lung tissues resulting in hemorrhage and localized edema. Now let's have the penetrating trauma. It occurs when a foreign object penetrates the chest wall. For the medical management, the goal here is to restore and maintain cardiopulmonary function. So the common injuries in penetrating trauma are pneumothorax and cardiac tamponade. For pneumothorax, it occurs when the parietal or visceral pleura is breached and the pleural space is exposed to positive atmospheric pressure. So we have types of pneumothorax. First is your simple pneumothorax. It occurs when air enters the pleural space through a breach of either the parietal or visceral pleura. Also, we have your traumatic pneumothorax. It occurs when air escapes from laceration in the lungs itself and enters the pleural space or from a wound in the chest wall. Lastly, we have the tension pneumothorax. It occurs when an air is drawn into the pleural space from a lacerated lung or through a small opening or wound in the chest wall. Now let's have the medical management. The goal here is to evacuate the air or blood from the pleural space. For the cardiac tamponade, compression of the heart resulting from fluid or blood within the pericardial sac, usually caused by blunt or penetrating trauma to the chest. We also have your subcutaneous emphysema. It occurs when air gets into the tissues under the skin and in the soft tissues. This usually occurs in the soft tissue of the chest wall or neck, but can also occur in other parts of the body. I believe this is the end of my lecture on management of patients with chest and lower respiratory tract disorders. I hope you learned something today. This has been Crazy Nurse RN Hub. Thank you and have a good day.